This is another in CPAC's series of capital briefings, and this event we're doing in conjunction with the California Health Policy Forum. It's an event focused on the issue of the safety net. We're talking about innovations for the future, but I think what we're all quite aware of is the huge impact on healthcare reform. And so I think the implications of the session as well as each of the presentations are related to the issues of healthcare reform as they're going to play themselves out in the next 2 to 5 to 10 years. I'm not going to make any other comments other than to say that, I think what we do is, and if you've attended our events in the past, and we do about 6 of these in the Capitol every year, is we try to take a look at not only the academic perspectives, if you will, coming from UC, since we are funded by University of California Office of the President, but also the sense of the experts that are out there in the field. So I'm going to give this to Karen.
Great, thanks, Gil. Welcome, everyone. I'm Karen Shore from the Center for Health Improvement, and delighted to see everybody for this afternoon session on innovation in the healthcare safety net. So, as many of you know, we send out a survey every year to legislative and state agency staff asking for their input on briefing topics, and this year, the safety net was the second highest rated topic, following only an update on health reform implementation. I think we have an insatiable curiosity about that. So I just wanted to point out a few items in your packets. You'll see on the right side the agenda, the PowerPoints, and some speaker bios. And then on the left side, the pink evaluation form, which we really would appreciate if you would fill out toward the end. And then a lot of materials that our speakers have identified that might be useful for you as further reading and items you might want to share with your colleagues. So we'll be posting all those materials on the California Health Policy Forum website after the briefing, and there'll also be a link to the videotape, which is being made, and that's the www.CAHPF.org, so you might want to visit that after the event. And I just want to offer a few thanks as well to our funders, the California Healthcare Foundation, the California Endowment, and the California Wellness Foundation, as well as to the folks at CPAC that have partnered with us in creating this event, and specifically Gil and Munoz and Giovanna Gomez. So thank you for that. And then just for today's presentation, as Gil said, we're really coupling the academic perspective with very applied. And we're first going to hear about who's using the safety net both today and what's likely to be happening in the future, and then what's going on in 5 different counties across California that we might be able to learn from, some best practices for what might be able to be done in the rest of the state. And then really turning to folks on the ground who are working every day to make some innovations in the safety net and create a more seamless system of care for people, both from the urban and rural perspectives, the county clinics, the clinics in rural areas as well as in LA County, and then also from the public hospitals. So really look forward to the presentations and to your questions toward the end.
Yeah, I'm really very fortunate to have as a guest moderator today Dr. Lou Vismara, who's a cardiologist by training and did spend a lot of time doing that as well. But I think in a lot of ways he's also was a founder and co-founder of the Mind Institute, okay, and is chairperson of the advisory board. But more importantly for me, when I first heard of Dr. Vismara, was in the creation of the Prop 10 Commission, and the very idea of having an initiative funded by tobacco monies, okay, that was going to provide services for, provide the resources for child care and oral health and a variety of other things for 0 to 5 population. In a lot of ways, I think that Dr. Vismara was kind of one of the leading lights in pulling that together. And I'd heard about his name before the initiative even surfaced, a year or so before it surfaced. Since Rob Reiner was the one that was given all the credit, but there was a lot of other people that really were actively involved, and certainly Lou was one of those lights. So I'm really glad to have Lou, who's also this consultant, principal consultant for the Senate Pro Tem, Darrell Steinberg. Dr. Vismara.
Thank you very much, Dr. Ada, for the very kind words. It's a pleasure and privilege to be here, and I, along with the rest of the audience, look forward on this very exciting forum. So without any further ado, I'd like to introduce our first speaker, who's Dr. Stephen Wallace, who's the chair and professor of the Department of Community Health Sciences at the UCLA Fielding School of Public Health, and he's an associate director at the UCLA Center for Health Policy Research. Dr. Wallace is a leading national scholar in the area of aging in communities of color and has published research on access to long-term care, by diverse elderly groups. His very extensive and impressive biography is included in the package. Dr. Wallace is a former Fulbright Fellow who received his doctorate in sociology from the UCSF School, and his topic today is Landscape of Safety Net and Immigrant Population After Healthcare Reform. Thank you for being here, Dr. Wallace.
Thank you, Dr. Vismara. I see on my first slide that I forgot a very important piece of information, which is the website for the UCLA Center for Health Policy Research. I will be reporting on a number of studies that we've conducted over the last year or two, and those are all available for free for download at www.healthpolicy.ucla.edu. So health policy is the key piece that you have to remember. I think it's pretty obvious given what we're talking about. Okay, so I'm supposed to be talking about after healthcare reform, but first we should talk about what is the safety net and where do we start. So I just wanted to start with a brief summary. This is from the Institute of Medicine. It's the generally accepted definition of what the safety net is. And the safety net are those providers that by mandate or mission organize and deliver a significant level of health care and other health-related services to, and this is the key part, the uninsured. And we often think about the uninsured by themselves when we think about the safety net. The other key part, though, is that it also includes people who are paying for their services through Medicaid, which is Medi-Cal in California, and other vulnerable patients. So when we think about the safety net, we shouldn't just think about uninsured persons, but we should also think about persons with Medi-Cal and other vulnerable populations that rely on those providers. So this is actually a little bit mislabeled. This is the current health insurance status of non-elderly people in California. I say who uses the safety net now because the two pieces of the pie that are pulled out, the uninsured and the Medi-Cal, are the groups that disproportionately rely on the safety net. So as you can see, about 37% of all non-elderly persons in California are persons who are likely to need recourse to safety net providers. And we're talking over 12 million individuals in that. So that's a substantial proportion of Californians who are being potentially served by the safety net. When you talk about vulnerable adults, we're talking about a number of different types of populations. So LEP stands for Limited English Proficiency. These are people who speak a language other than English at home and who speak English not at all or only a little bit. And you can see that 42% of persons who are limited English in California are uninsured. Another big group are single adults with no children. Almost 30% of them have no insurance. I picked out particularly vulnerable occupations. Most uninsured people in California are in families with a full-time year-round worker. And this just shows that if the person is working in construction, they themselves, almost 40%, about 2 out of 5, have no health insurance. So it belies the thought that people without health insurance are somehow not engaged in the economy. In addition, about 40% of non-citizens, that's the immigrant population that we've been talking about. And I think when we're talking about immigrants, there are sort of 3 key dimensions that I'll come back to at the very end. The first one is the first bar, the limited English proficiency. So California, over a quarter of Californians were born in another country. Those are immigrants. Important part of our economy and our society. People who have limited English are disproportionately, almost entirely immigrants. And so when you think of immigrant populations, one of the characteristics that makes them particularly vulnerable is difficulty with the English language. Second is legal status. So once again, if you're talking about non-citizens, people who are immigrants who may have a green card or they may not have a green card, they may even be U.S. citizens, but citizenship status can create problems. Sometimes there's rumors, information that circulates in immigrant communities that's not necessarily correct, but it affects them nonetheless. And the third aspect is that immigrants do tend to settle in immigrant enclaves. So we're talking not about people who are scattered randomly all over the state of California, but we're talking about people who live in particular neighborhoods where a lot of other people are limited English, where a lot of other people have immigrant status, and where oftentimes there are not a lot of medical care providers. And so, as you can see, the uninsured, half of them also have no usual source of care, and that's one of the problems with having no insurance, is you have very limited access to health care. For those who do have some sort of access to health care, what this slide shows is that the number one slot for people with no with no insurance, the number one place they go if they go anywhere are safety net providers. The definition of safety net providers is an institution that has a particular focus on the uninsured and Medi-Cal populations, and so it should be no surprise that those without health insurance disproportionately go to safety net providers. This is for outpatient services. And when you look at people who have Medi-Cal, that other target group for the safety net, they also disproportionately go to safety net providers. They're about even for children, 1.3 million going to a private doctor's office or an HMO, 1.26 million going to safety net providers, and then the balance without reporting a usual source of care. So about half of those on Medi-Cal are using safety net providers. So what's the Affordable Care Act, otherwise known as health care reform, Obamacare, whatever you want to call it? It's coming, and it's coming to California. We're one of the leaders in the country in being prepared for it. It will have a major increase in Medi-Cal coverage. There are a couple dimensions there. First of all, Medi-Cal currently does not cover adults unless you have children. So with the Medi-Cal expansion, all persons who are below 133% of poverty will be eligible for Medi-Cal. So that's a significant increase. And they're also dropping the asset test. Right now you have to prove that you have a very low number of assets, value of assets, which creates administrative difficulties, and so that should hopefully simplify enrollment. Second, there will be subsidies provided for purchasing private insurance if your income is above the Medi-Cal eligibility line. There'll be a sliding scale up to 400% of the federal poverty level. And there'll be subsidies for small employers to help cover their workers as well. So California is busily constructing its state exchange that these subsidies will be provided through. Will provide a health insurance market that's regulated and affordable. And that's a second route through which people can get health insurance. And then third is there's already been a major expansion in funding directly to community health centers. And community health centers are one of those pillars that we think about when we think about safety net providers, to both increase the physical capacity as well as the number of patients that they can serve. So there'll be a net increase in the number of persons with insurance and with access to health care. Now, not on the slide is a fourth item, which is a potential complication, which is currently hospitals that serve a lot of Medi-Cal and uninsured patients get a special payment called disproportionate share funding. And that special funding, which is supposed to help compensate for the low payments of Medi-Cal and the no payments from the uninsured, will be decreasing dramatically. So while community health centers actually are getting an infusion of funds, safety net hospitals are in a iffier situation. So that's the landscape that we're looking towards. The people who will be eligible for this new expansion, including those who are previously uninsured, what you can see here is that about 1/4 will be eligible for subsidies through the exchange. About 40%, 2 out of 5 of the current uninsured will be eligible for Medi-Cal or Healthy Families, which is, by the time 2014 rolls around, I believe will all be Medi-Cal. And about 16%, 15.9% will not be eligible. That is primarily because they don't have residence status in the United States. So you'll see a large group of Medi-Cal recipients who will be new recipients, and you'll see a fairly large group of people who will be coming through the exchange. So at the UCLA Center for Health Policy Research, in collaboration with UC Berkeley, we've done a simulation. We've taken current patterns of health insurance, look at when people buy insurance, what motivates them to buy insurance, and projecting forward to 2019, when healthcare reform has finished enrolling as many people as it's likely to enroll. This is the landscape that we expect to find. Now, I'm afraid the red doesn't show very well on here. That's going with the white bars. Those are basically the Medi-Cal population will be about 26% of all non-elderly persons in California. The uninsured but eligible will be about 3%, and those subsidized through the exchange will be about 6%. So particularly the Medi-Cal and the uninsured not eligible are those who are still going to be disproportionately reliant on the safety net. Or if you add up all of these pieces, about 35%. So about a third of the state currently relies on the safety net, in either actually or potentially. And in 2019, you can expect to see a rather similar proportion reliant on the safety net. So sometimes you hear in the news that we're going to insure all individuals and that will take care of access to health care. And it implies that the safety net is not going to be important. But actually, when we see healthcare reform fully implemented, the safety net will be actually just as important as it is today. Okay, and you can tell that, you don't have to take my word for it, by looking at Massachusetts. So current Affordable Care Act was modeled on the Massachusetts health insurance reform that Governor Romney signed into law in Massachusetts. And as you follow what happened in that state, you can see that safety net providers, they went up to 300% federal poverty instead of 400%. So just going across, currently all adults in the state of Massachusetts under 5% are uninsured, and about a little over a quarter are on public insurance. If you look at just low-income individuals, the numbers increase for public and uninsured. And then if you look at the people who are using the safety net, once again, it's disproportionately public insurance and uninsured. Actually, the safety net in Massachusetts became even more important for the uninsured. As a proportion of the uninsured, safety net providers in Massachusetts now provide more care than they did before healthcare reform. In addition, the total demand on safety net providers in the community health centers, went up by almost 1/3. The number of patients seen went up by almost 1/3 before and after healthcare reform in Massachusetts. And the use of hospitals went up about 3 to 5%, but it went up the same for those who were part of the safety net and those who are not in the safety net. So to summarize, the safety net demand went up in Massachusetts. The non-safety net demand remained relatively constant in community providers. In hospital providers, safety net providers went up a little bit, at about the same rate that non-safety net providers went up. So what we can, I think, fairly safely predict for California is an increased demand in both the need for and use of safety net providers in the community. And this is why people in Massachusetts said they were using the safety net. 79.3% said they used it because it was convenient. 73% said it was affordable. Of those who responded to the survey in a language other than English, 8.2% said because it was language accessible. So I think what's important to think about when you're thinking about immigrants is, I mentioned earlier, immigrants tend to settle in immigrant neighborhoods. And one of the key reasons that people were continuing to use safety net providers in Massachusetts is it was nearby. So it would be logical to assume that the safety net providers in California, as people go from uninsured to insured status, as they sign up for Medi-Cal or subsidies through the exchanges, are going to continue to go to the providers who they've been seeing in the past and who are convenient to their neighborhoods. And if you look at low-income, minority, and immigrant neighborhoods, they're primarily safety net providers. What this will result in, as people get insurance, even if they're going to the same providers, is they will have better access to preventive care. They will now have coverage for flu immunizations, for mammographies, for colonoscopies, for the types of prevention that will keep them healthy longer. They'll have better access for services for chronic conditions. Latinos in particular, as well as African Americans, have twice the rate of diabetes as the non-Hispanic white population. It increases with lower income as well. That's a population where if you get ongoing careful management, you can prevent the complications of blindness, amputations, renal failure, and a host of other conditions. So we should be seeing improved access and use of services. So what are the future challenges as we move into the post-healthcare reform era? I think the biggest one for immigrants are going to be language barriers to enrollment. It's anticipated that 2 out of every 5 persons signing up through the exchange for health insurance, for that subsidized private health insurance, are limited English speakers, and a larger proportion will be limited English who are in Medi-Cal. Reaching those individuals to inform them of the new benefits, of informing them of their eligibility, how to sign up, getting them signed up, getting them connected with providers who can provide adequate care to them is going to be a huge challenge. Currently in California, less than half of people who are eligible for Medi-Cal are actually signed up for Medi-Cal. We know we can do better. In Washington, D.C., 88% of people who are eligible for their Medicaid program are signed up. So we need to make sure that we do an adequate outreach and enrollment to be able to make sure people who are eligible for the programs actually get them. And the Blue Achieving Equity by Building a Bridge from Eligible to Enrolled is one of the reports that we did. That's actually hyperlinked. If you click on that, it'll take you there. The second challenge, I think, are mixed status families. Mixed status families are where you have a parent who's an immigrant, whether they have legal status or not, and they have children. When they have children in California, they're U.S. citizens. Yet, among the 1 million children with immigrant parents, the parents are not always comfortable or knowledgeable about the fact that their children are eligible for Medi-Cal and for subsidies. So we need to do a lot of work to make sure that parents know that their U.S. citizen children are eligible for these programs, whether or not the parents are, and that it will not affect chances for citizenship or their legal status. And then last but not least, we need to be concerned with the capacity of the safety net in Massachusetts. The community-based clinics went up by 1/3 in their use. They had to scramble to try to maintain adequate access to services. And these are clinics that are particularly important because they do tend to offer programs in language. They provide programs that are in immigrant and low-income communities. And they're the ones most able to provide services to Cambodians in Long Beach, the Hmong in Sacramento, Armenians in Glendale, Afghanis in the East Bay, not to mention the hundreds of thousands or millions of low-income Latinos who are limited English speaking. So in sum, we need to pay attention to the safety net as we move to healthcare reform. The expansion of health insurance actually provides new challenges, even though it brings new revenues to the safety net. And I look forward to listening to the rest of the panel and hear how it's getting ready for this new group of persons. Thank you.
Excellent. Thank you so much. I believe we have 5 minutes for questions and comments. Are there questions or comments? Dr. Wallace, I have a couple of questions from my antiquated background of practicing cardiology. 2 things. As a cardiologist, I was often struck by the disparity in reimbursement, that for a procedure that might take 15 or 20 minutes, I would get reimbursed for a very, very fee that was often inappropriately high, whereas preventive care, instruction, et cetera, would often go completely unreimbursed. And it seems that with the exciting and important changes that you have outlined for us, there, again, these disparities in reimbursement may be exacerbated. Do you have any thoughts in terms of whether these changes in the system may provide an impetus to change reimbursement, or how are we going to deal with that problem down the road?
Yeah, I think that's an excellent issue. That's been an issue that Medicare has been dealing with for a number of years because most healthcare is paid for by procedure, and counseling a person on their diabetes isn't a procedure. So Medicare has been trying to readjust the payments based on the codings that you put in, so the primary care physicians actually do get a higher reimbursement for doing things like counseling. And the ophthalmologist who spends 10 minutes with a laser is doing a very important service, but gets a little bit less. But I think that's a systemic problem with the reimbursement system that we have.
Excellent. Thank you.
Let me raise another question. The California, for a number of years, has had a healthy set of what we call state-only programs, where, for instance, both in Medi-Cal as well as in healthy families, if illegal immigrants under the 5-year bar, they are covered, but under state funds, as opposed to with federal matching funds. And I guess there's been a lot of questions as to whether or not the state and this particular governor in this administration intends to continue those kinds of state-only programs, particularly since Healthy Families is now transitioning to Medi-Cal.
Right. So the state does provide eligibility for Medi-Cal and Healthy Families from the day a person becomes a legal resident in the state. And for the first 5 years, that's paid 100% out of state money. That group is not included in healthcare reform under Medi-Cal, but they actually are eligible for the subsidized purchase of insurance through the exchange. So I don't know that we actually know how that's going to work, because that will, if California drops that, that will cause even more confusion, because people who think they're eligible for Medi-Cal might be eligible to go to the exchange and get a subsidy, but it would be different, and then after 5 years they would no longer be eligible because you're either eligible for one or the other. So that could create a large amount of confusion among the population, which is already confused over the various eligibility rules, which would undoubtedly result in a higher proportion of uninsured.
Excellent. Our next speaker is Dr. Annette Gardner, and her topic is local initiatives to integrate the healthcare safety net. Dr. Gardner is an assistant professor in the Department of Social and Behavioral Sciences in the School of Nursing, UCSF. And today, Dr. Gardner will discuss her recently completed study on the safety net integration activities in 5 California counties and the financial impacts of federal and state reform on California community clinics. Dr. Gardner, welcome.
Thank you. I always feel fortunate as a researcher to be able to come to the table with pretty good news, and I have some today, even though these are very uncertain times. First, I'd like to thank our study partners in this initiative. It was included the UC Berkeley Center for Labor and Research and Education, supported by the California Endowment. And I'd also like to give a special shout out to the 5 counties that participated in our study, including Susan Ehrlich to my left from San Mateo County. And I'm actually very grateful that she and Louise are here to really put a face to the data that I'm going to present today. First of all, let me just put on the table a very simple definition of integration I think we can all get behind. We think of this as a systems approach to the provision of comprehensive, coordinated, culturally competent, consumer-centered care. Yes, all those words start with C. We think of this in terms of having 2 organizations come together in partnership for the purpose of improving outcomes. And sometimes, as we are seeing with the integration of mental health and primary care, these are 2 organizations from different silos, different paradigms. Sometimes it's also between the county and the non-county providers. And the goal is to reduce the fragmentation we see throughout our healthcare delivery system, the duplication of services, as well as reduce costs. So we're on the road. Unfortunately, this picture leaves a little unclear where we're going, but it looks like we're going together. And we have a lot of help on the way. And if you've read the Affordable Care Act cover to cover, you know there are lots of provisions in there to facilitate integration of the healthcare safety net. The accountable care organization pieces, the bundled payments, both payment and delivery system reforms. And I'll leave it to you to go read the Affordable Care Act to tease out all of these one by one. There will be some bumps on the way. Our safety nets are strained. We're already seeing that there are issues with access to care, and when there are issues with access to care, that compromises care coordination. We see that funding is fragmented, which doesn't help with anything, and I'll go into more detail on that in a little bit. Certain provisions like the accountable care organizations are not mandated under the Affordable Care Act, and as we know, all communities have their unique features as well as the stakeholder or providers configurations, and those require flexible strategies. So we did this rather simple, quick little study, and basically we wanted to describe safety net integration and what is actually happening in 5 counties where we knew there was considerable activity underway. And we were looking in counties that said they had particularly county and non-county partnerships going on, also between clinics and hospitals. We wanted to drill down a little bit, see what it was that predisposed these 5 counties to be able to do a variety of integration initiatives. We wanted to see if we could capture best practices and lessons learned that could be applied elsewhere. Also, we wanted to be able to develop some recommendations for decision makers on what it would take to facilitate safety net integration. Very quickly, our study was to talk to the key stakeholders or safety net providers in each of these 5 counties, and I'll show you who those are in a minute. And then we drilled in a couple of areas. We did a cover the waterfront approach to all types of integration activities. We asked about contextual factors that facilitated and impeded integration. We asked about resources, IT systems, and these best practices that I'll get into in a little bit. So I'm a big fan of counties. I really do think they're health stewards, and they really are under their 17,000 obligations, and I also see them as health innovators. And we've actually got a long track record at UCSF in documenting this around expanding access to care, such as the Healthy Kids initiatives in many of our counties to expand access to care for uninsured children. So we've been looking hard at them since about 2000 and have a good track record of using a variety of approaches. So, I'm sorry I couldn't put the 5 counties on this map, but basically we did interviews in Contra Costa, Humboldt, San Diego, San Joaquin, and San Mateo. And we picked these 5 counties not just because they're doing quite a bit, but because they represent in many ways the spectrum of county healthcare or safety net delivery systems. We have 3 that are, I should say 2, which are considered public-private partnerships, where the county has a strong healthcare delivery system but partners with the non-county federally qualified health center and a public hospital or a UC hospital. We also have 2 private systems where the county does not provide healthcare delivery systems but contracts them out to clinics and hospitals. And then we have a strong public system, which Susan can get into in a little bit when it comes to San Mateo, where the county has been the primary provider, although they are partnering a little more with other providers outside of the county healthcare delivery system. And then I have more information on each county, but it's in your packet in the report. So what I'm going to put up are the gaps that I think many of us are aware of and have been aware of for some time. And I don't want to read through them all except to say there are a lot of them in the areas of population, services, diseases, conditions, and skill gaps. I think what was new to us this last go-around, because we ask this question all the time, is that in the past, it's been access to specialty care that's been a problem, but increasingly it's now access to primary care, which is troubling given that so much of the Affordable Care Act really depends on expanded primary care capacity. Anyway, just to say that we know county healthcare safety nets are strained, and these are a lot of the issues. So we asked, tell us how integrated your county is and your county healthcare safety net. And when we step back, we find that despite the different types of models of these 5 counties, they actually see themselves as being fairly integrated, around 6 or 7, which is to say they do a lot of projects together. They're not quite an integrated set of organizations in that they share funding. They're ways from that. But with the 3 counties that have their own healthcare, county-run healthcare delivery system, there's a little more integration in that they are able to partner across the different agencies, the Medi-Cal plan, the hospital, and the clinic. So that's the one difference we see between the 2 types of delivery systems. But overall, these counties think that they're already doing what it takes to lay the foundation for healthcare reform. I think San Joaquin is the one that's perhaps it rates itself highly, but as you'll see later, it may be a little further behind than the other 4. So here is our cover the waterfront approach to what is integration, and I'm not going to read all of these activities. There are 28, and the 5 counties all are doing between 25 to 28 of these activities. And they're system level, provider level, and as you'll see in the next slide, patient level. And I just highlighted the ones where we asked, if you're not doing them, are you intending to do them? And we found 3 areas where activities proposed. And for this tells us, well, what can we anticipate? Where might there be additional support required? But otherwise, all of these activities, for the most part, are underway now, which is to say these counties are silly busy. They have got so much going on. It's hard to wrap your mind around it. On the second part of our list, you'll see that the Health Information Exchange and the e-portals are the 2 activities that are in the proposal or still being discussed phase. P doesn't mean you've actually committed, but it shows that it's on the tip of the tongue. But you can see that there's quite a bit of IT activity underway as well. When we go and look at the stakeholders themselves, and I actually mislabeled this slide, although I'll tell you truthfully, a lot of safety net integration comes down to the healthcare providers and having a team approach, not just an organization approach to integration. So the animation is all gone on this slide, which makes it really tough to read. Okay, well, let's see. We'll just talk about the stakeholders. But basically, if I were to tell you how this slide plays out with the counties, you would see that basically San Joaquin County, which is in green, lags a little behind. But anyway, it shows you a mixed level of activity by stakeholder type as well as counties. Not all stakeholders are doing every activity. This tells you what's proposed, and again, you can tell San Joaquin has things in the pipeline. It's lagging behind, but it also tells you that the clinic and the Medi-Cal plans, or mostly the clinics here, are anticipating being very busy into the near future. So when we talk about types of initiatives, we see that nearly all stakeholders are doing some of the same things. They're doing activities to facilitate provider-level integration, such as electronic disease registries, panel management, communication between organizations, mental health primary care integration. You see a lot of patient-level integration going on, a lot of navigator and community health worker activities to connect patients to care, facilitating access to care with language access and telephone systems. And then when you look at IT, again, a lot of activity going on multiple fronts with multiple applications. All of these counties are doing something to get people enrolled electronically to facilitate continuous coverage, and that some of these countries are developing the data archives to be able to use that data and to inform decision making. However, getting IT systems to talk together or talk to one another is still a big issue and remains to be tackled. So what is it about these counties? What do they have that makes this integration possible? A lot of these factors we've seen in the past: strong partnerships, strong leaderships, presence of a safety net collaborative, lots of infrastructure that facilitates planning and implementation. The barriers are about the same thing. It's all about the money. Inadequate Medi-Cal reimbursements, state and county cuts, capacity issues. They're very strained despite how affluent some of these counties are. There are some differences by each county. Some of these counties have a Medi-Cal managed care plan, which helps a lot, but it doesn't mean that the other counties aren't able to find other entities to do some of these planning and implementation of activities. Geographic barriers, although we were talking about that nearly every county has a rural pocket, but these geographic barriers are more pronounced in Humboldt County. Market share competition varies. We see it's a little more pronounced in San Diego County, where all of this care is provided by private providers. And then the financial situation varies somewhat from county to county. And as you know, in San Joaquin County, Stockton has declared bankruptcy, and they're much further behind than the other counties financially. Funding. The funding is piecemeal. That's pretty much the summary take-home point to this one. There are opportunities, but it doesn't cut across the state. There are different strategies to securing funding, some being more entrepreneurial, some counties being more cautious around expending capacity to get resources. And there are opportunities, be it under the Affordable Care Act, as I mentioned, or the Medi-Cal waiver and the LIP program and others. So at the end of the day, when we stand back and we ask these counties, so are you ready for health care reform? And they have said yes. They agree that they have the capacity and the resources, though there's a little disagreement in San Diego and San Joaquin County. So that's the good news. So in summary, what we find is that, yes, there's a lot of activity underway, different types of integration activities underway, though it varies by stakeholder. We can see what some future areas of involvement are around accountable care organizations and HIEs and e-portals. We see that it really helps to have nimble organizations, strong partnerships, strong commitment, and that IT will continue to be an area of high activity, and that, yes, good news is that these 5 counties are doing it, but there's still a lot of work to be done and many challenges both now and on the horizon. Now, my time is up, so what I'm going to do with these next few slides, which were all about the best practices, and I still haven't found a way to present it, I'm just going to say, please look at the study that we put in the packets, because you will find 20 lovely detailed text boxes which tell you about the types of initiatives that are going on in these counties. And our whole point with that was to put something in print that we could share across other counties. And the topics are pretty much what you would expect to see: HIT, mental health primary care integration, specialty care access, and patient care coordination. Those were our 5 buckets. So I'm going to leave you with that, with the nudge to take a look at the survey, go past the data, go look at those best practices. These challenges are in there as well. It takes a lot of hard work is what it boils down to. So with that, I will leave with the recommendations, because I came all the way to Sacramento to give these. So basically, we're mindful of the state budget and enormous constraints on funding, but we did find a few areas where you could provide targeted support, and that's on those proposed activities. The other thing to look at more closely is IT infrastructure development, as we said, about interoperability issues. Support for the local infrastructure around coalitions and collaboratives. And then in terms of informing state policy, we think we keep beating the drum on tailor your strategies to meet individual county needs. No one size fits all. To keep an eye on the county state responsibilities around the 17,000 obligations, really leverage everything in the Affordable Care Act, bundled payments, and provisions that support integration, such as a health benefit exchange. And that's it for me. Thank you.
Excellent. Thank you so much for that very focused and informative message, Dr. Gardner. Questions, comments?
I have a comment and a question, I guess. When you take a look at the 5 counties and that overall rating system, that 7.2, the 2 highest counties with a 7.7 in Contra Costa and a 7.5 in San Mateo. And they've been around, the managed care plans have been around there since the PHP days. We're talking about 20, 25 years. So is that an indication that this kind of integration really does take time? And the kind of integration that's going to happen, presumably in virtually every county, at least most of them, will take time. It won't happen overnight.
Well, you may have to parse it out by the type of integration activity. because some of these things like the care coordination, outreach enrollment, so that would have been, say, with the SCHIP funding, the ORU funding, so some of that's a little more recent in the last 10 years. So I think it depends. You know, we've been going at IT also for a while, but whether you need a Medi-Cal managed care plan is my bigger question, or a county delivery system, and maybe Susan can speak to this a little more. I'm not so convinced, because I think that, and that's why we like going to San Diego County and Humboldt County. We go repeatedly. Now, I think it's worth noting San Joaquin County has an integrated system like the other two, but as you know, they've been, and for a while we saw that in the early 2000s, they were making very good progress. All their stakeholders were in alignment, and I would have had them on par almost with Santa Clara and the other counties, but they've really had some, I think, had to deal with some greater hardships around the rate of the uninsured and the like. So, again, I think it depends on the type of initiative, and it depends on the county.
When you're speaking of integration of systems, do you have a sense whether the doctors and the primary care providers, the people who are going to be delivering these important services, are they going to be involved in being involved in the services and the infrastructure that often extend beyond the walls of the clinic or the hospital or the office?
Right, and that's the interesting piece about the patient-centered medical home and how much that's pushing on physicians. And the other piece is what actually that slide by mistake labeled interprofessional care. And I know from some other work in the VA, which mirrors the patient-centered medical home, there's a lot of training going on to get nurses and doctors to train together to play nice and work nice in a team model approach in a clinic setting, but also to do more around continuity of care with patients so that it is partnering with the patient and his or her family around care management and the like. So yes, it's got to, doesn't it? Really?
Absolutely. I learned early on in medical school to always listen to the nurses and do always what they said. So I'm glad you're implementing that. Another quick question, if I may, about about IT. It certainly sounds that it's an important in terms of the infrastructure, et cetera. As part of your project, did you actually look at telehealth in terms of delivering services in addition to providing access to them?
Right. I'm so glad you asked, because that is one of our little text boxes in our report. It's the telehealth network up in Humboldt County, where we have a good paragraph describing its origins, its the number of practitioners and sites and how many patients served and the like, and their partnerships with like UC Davis and the like. So we capture it that way. We also, I think, note in that table all the different types of IT, and I can't remember if telehealth is one of them, but we know that telehealth, telemedicine is a big component.
Awesome. Thank you.